That's the one that's on that one's definitely for sale.
Yeah, that one.
Oh, yeah. Cool.
I'd like to buy it. I'm like, there's a ton of space for you.
All right.
Oh, goodness. I'm sure.
But definitely.
Revamp it.
Yeah, the stuff inside. But it's good.
Most people continue to fill in this room, usually filled up to capacity by 12:15. So I figured since we're navigating the cases, we can get started. You mentioned. All right, guys. Hello?
Yeah, she finished and she's 20.
Sorry.
Hello. All right, guys. We're going to get started with today's lecture, continuing our acute care series, which we have only just a few more sessions of it left, going over our high yield inpatient topics. Today will be our debut GI topic of the acute care series, featuring our own Dr. Hines, who you will see on service, or if you're doing a GI consulting rotation or later in the year. And today we're going to be focusing on GI bleed, which is extremely high yield, and you'll see plenty of, I'm sure, just within a couple of months here at the hospital. So without further ado, I'll turn it over to Dr. Hines.
Hi, everyone. I'm relatively new to Pennsylvania Hospital. I just finished my first year, but I've been in Philly for a while. I pretty much did all my training, med school and beyond at Temple, so very familiar with the area. I'm really excited to be here and get to know you guys. I will be gone for 3 months and 6 weeks, so don't worry me too much, but I will be back. Okay, so GI bleed. Okay, so before we get started, does anyone know, so we're going to talk about upper GI bleeds, lower GI bleeds. Does anyone know, like, what's the cutoff? What is upper GI? What is lower GI anatomically? Okay, what is the ligament of Treitz? Where is that? Okay, yeah, so it's pretty much kind of like the flexure of the duodenum and the splenic flexure. So we can stay on this.
Oh, so
Yeah, stay on this until. Okay, oh, forgot my goals and objectives. Okay, so we're gonna make sure we know the differential diagnoses for upper GI bleeds, lower GI bleeds, hopefully recognize the clinical presentations of and understand the evaluation of both types of bleeds, and then compare and contrast those treatments. All right, so yeah, so this is kind of where we talk about what the difference is between upper GI bleed, lower GI bleed. And you can see the duodenal jejunal flexure there where it turns, and that's how we differentiate. All right, so let's get started with our first case. So this will be case-based, one for each. So we have a 32-year-old male, type 1 diabetes, hypertension, HFpEF, ESRD on peritoneal dialysis. Initially coming in for like not really GI symptoms, muscle cramps, fatigue, blurry vision, dizziness, nausea, vomiting, abdominal pain. On review of systems, does have some chronic diarrhea. Admitted to the ICU basically for DKA, and he's eventually transferred to the medicine floors. So as he is going to the bathroom on the medicine floors, he's like feeling a little dizzy, lightheaded. The nurse note says, patient found to be incontinent of bloody stool, RRT called. So you guys, I know this is mostly geared towards interns. I know some upper years also come, but you know, my big thing for interns is, you know, what are you going to do next? Stable versus unstable. I think that's the biggest takeaway from like intern year. So what do you do next? What do you want to know? So we can go to Menti now. Right, I'm gonna try this thing. Okay, so you can do present. Okay, so if you guys can go to menti.com, type in that code. It's menti.com.
It's up here at the top.
Yeah, and then type in that code. You should be able to free text. What do you want to know next? What are you gonna do? RRT is called and you're like the first one in the room.
3, 2, 5, 6.
All right, vital signs.
Yeah.
Good. Let me know if it's working or not working. Stats, BC, physical. Good, good. Okay, so I want to know vitals, right? Because that's going to help you. Is this guy stable, unstable? Do any of you want to know what type of blood it was? Right, that'll help you differentiate. You want to know if it's upper versus lower. Yeah, history of bloody diarrhea, red or black. Great. FOBT, not gonna lie, the bane of our existence. If there's obvious blood there, we don't necessarily need that. Okay, so great. So you guys are thinking of like symptoms, vitals, anything you'd want to know in like the history? Prior episodes, good. All right, type in someone type in some other stuff about like maybe history. What would be helpful to know in the history? Anticoagulation, good. NSAID use, perfect. Hemorrhoids, dizziness. Okay.
Pain versus
Non-pain versus non-pain, very good. Okay, alcohol use, great. Okay, so I think that's a pretty good. You guys have a good idea of like what you want to get, what you want to know. Liver disease, excellent. Vomiting blood, perfect. Okay, so let's go back to the case presentation. There we go. All right, so there we go. Okay, so blood pressure is 85/46, heart rate 156, afebrile, stable, unstable. Stable, yeah. He's got hypotensive, he's tachycardic. These are classic signs of hemorrhaging somewhere, something crazy is happening. He did respond a little bit to some fluids. No NSAID use, alcohol, not on blood thinners, INR is normal. No vomiting, no gastric surgeries. That's something I also mentioned. And his hemoglobin really took a tank. He is a young guy with a lot of chronic medical problems, so his baseline is kind of in the 7s to 8s, but clearly something else is going on here. And then go next. And this is just his BMP, creatinine, not very helpful at this time right now because he has ESRD, but so far from like a DKA perspective also seems to have things okay. All right, so let's get to the nitty gritty. So go back to Minty if you can. All right, so you've got this guy, the complaint, when you looked at the bloody stool, it was actually melanoma. So what is your differential diagnosis for an upper GI bleed? You could just go.
PUD. Oh, wow.
Okay, lots of PUD. No one else write PUD.
Varices are coming up now.
All right, great. Leister. Erosive gastritis, esophageal cancer, that's a good one. Boy. Can anyone who wrote Mallory Weister just tell me briefly what that is?
Essentially, after repeated episodes of vomiting, they tear between like the esophageal lining, causing bleeding.
Great, awesome. So yeah, so classic history is I vomited like a few times, nothing was there, and then after I vomited again, that's a very good thing in the history to differentiate to kind of help you see if it's that. Okay, ruptured peptic ulcer, cancer, tonsillectomy. Anything more? AVM, nice. What risk factors does this guy have for AVMs? ESRD. Do you guys know another risk factor to have AVMs? Okay, great. What's that called? Very good. All right.
Nice.
Okay, so we can go out of that now. All right. Okay, so you guys hit the money on most of the things to consider, right? So on the left over here, we have peptic ulcer disease. That on endoscopy looks like a very nice clean base ulcer, no recent stigmata of bleeding, right? And it looks like it's on the way to healing. You guys also mentioned erosive gastritis, duodenitis. So you see all those ulcerations on the side. Okay, yeah. So Mallory Weiss tear, that's a good one. So when you're looking at the esophagus, right here, it's a nice juicy tear for how that patient was bleeding at the time. Varices, also another important thing, obviously, because that can be very life-threatening. So this is what esophageal varices looks like. AVMs, so these are like abnormal tangle of blood vessels. We typically treat these with APC, argon plasma coagulation, which is just a very superficial burning to clot those. And then, yeah, doulofoilage. So you're going to see that a lot in your very unstable patients, right? Because it's a submucosal artery that's eroded through the gas lining of the wall. It's just spurting out. So definitely with particularly unstable patients, that's something that you think of versus maybe AVMs can present as not stable, right? People can ooze from those. Gastric and esophageal varices, you think definitely more not stable. No one mentioned GAVE. It's, not a classic unstable presentation, but you also have to think of the causes of people who can like ooze over time. So with GAVE, there's the watermelon stomach. You don't need to have portal hypertension to have GAVE. You can have GAVE for several other reasons: CKD, cirrhosis, systemic sclerosis, portal hypertensive gastropathy, and your cirrhotics as well. And then some other ones I mentioned, we mentioned gastric cancer. So I don't know what Cameron lesions are. So Cameron lesions are when you have a hiatal hernia and you get erosions within that hernia, because if it's sliding up and down a lot, it can cause some irritation. So it's basically kind of like ulcerations, ulcers, erosions within that sac. Esophagitis, gastric cancer. I've never actually seen this so far, but I think this is one of those like don't miss aortoenteric fistulas. Obviously, the patient would be very, very sick, but something to think about if there's nothing else. Okay, so we can go next. All right. So we're talking about sick versus not sick. We want to look at the stool, obviously. So, I feel like I wouldn't be a GI doctor if I didn't show you guys a picture of true melena. A lot of things that I learned in fellowship was also sometimes if you can't tell, if that's black, that's tardy. But sometimes if you can't tell and it's just dark, always put it on toilet paper or a paper towel, smear it. See if it's, because a lot of times if you smear it, it actually can look more brown than black. And that kind of helps you as well. And then don't forget the increased BUN to creatinine ratio. That can help you differentiate if something is truly an upper GI bleed. For our guy here, he has ESRD, so it was like kind of hard to tell. It's not very useful, but it occurs because you have increased urea production from the digestion and absorption of the blood from the upper GI tract, and then you got your pre-renal injuries as well. So that makes your ratio, so greater than 30 can be suggestive of an upper GI bleed. So these are kind of the different things that you want to use to help you, one, identify if it's a true upper GI bleed. But don't get me wrong, you'll see BUN creatinine ratios that are not elevated like that if it's not necessarily as acute, because people can be slowly losing over time as well. Okay. All right. So back to Menti. There she is. All right. So this guy's unstable. He's bleeding. What are you doing for him?
2 large diabetes.
Okay, massive transfusion protocol, nice, call GI. Okay, IBPPI. So how do you guys feel about octreotide? This guy doesn't necessarily have any documented history of cirrhosis or varices or anything like that. Do you guys find in your practice that you're kind of doing it anyway, or like a just in case thing? What do you guys typically encounter?
I think the data suggests that octreotide doesn't do anything unless they have like blood hypertension.
Yeah, exactly, right? Because we're talking about slowing blood flow. Although I will say I've gotten the last time I was on service, I got a call from an outside hospital of a guy who all he had was a history of drinking. But he had recent imaging that didn't show cirrhosis or anything. And the ED attending is calling me saying he's given octreotide and all these things. And, he wasn't having hematemesis or anything like that. When I asked him, why are you doing octreotide? It doesn't look like there's any evidence of cirrhosis. I said, I'm just throwing everything at him until he gets to you guys. So, for what it's worth, people sometimes do it, but yeah, I agree. Wouldn't necessarily be my first go-to because there's no necessary evidence of that, but sometimes if you don't know, you don't necessarily, if there is any question of cirrhosis or varices, you don't have to wait for confirmation of that, obviously. You can always like pull these medications back. Okay, someone said Blatchford score. What's that?
Crystal breathing.
Okay, all right, nice. All right, what else do we have?
Type and screen.
Okay. Anyone want to upgrade him to the ICU? Yeah, let's do that, okay. All right, so we have our good kind of your basic care, your 2 large bore IV, fluids, blood, PPI. Okay, and type and screen, important. EGD, call GI, yes, definitely. All right, let's go back. Yeah, okay. So a lot of this I pulled from like our guidelines, and I'll add in like sprinkle kind of what we do, but like resuscitation is key, right? This guy had a hemoglobin of 3 something, like he needs to be resuscitated before we even consider scoping, because that can be, one, it can increase his risk of an endoscopic procedure, but you've just got to get the fluid in him. So the guidelines mention restrictive red blood cell transfusion of 7 in hemodynamically stable patients. In those who are obviously unstable, you do the massive transfusion protocol. Threshold of 8 you can consider for those with like existing cardiovascular disease. Interestingly enough, our guidelines actually don't have a recommendation for or against pre-endoscopic PPI therapy for patients with an upper GI bleed. They don't say don't do it, but they actually don't necessarily say it decreases the risk of bleeding. Obviously, if you go inside and you see an ulcer and things like that, yes, that person needs PPI, but we're talking very specifically about like pre-endoscopic. Do most times we say do the PPI? Yeah, because, you know, peptic ulcer disease is the most common cause of upper GI bleed, and the downsides to the medication are not that much. But I just thought it was an interesting thing to point out that it's actually not recommended for or against, and it's not a slam dunk. I think they used to do that more. And then the difference between IV drip PPI versus, you know, high dose twice a day. They haven't really shown studies of it, one being more superior than the other. I think I feel better when someone's on a drip in the ICU versus a PPI BID, but once again, studies haven't actually panned that out. And then the other thing that the guidelines talk about is erythromycin, right? A prokinetic to try and move the clot. That actually really does help us. I've done cases where we've been able to get it in that 30 to 90 minute time frame, because our scope, the amount of suction we can do basically on the regular scope is about that big. So if you have big blood clots, which is another reason I bring this up. This has nothing to do with this talk, but sometimes when patients are really fecally impacted and they want us to just do a colonoscopy to remove the stool, this is the whole size of the hole I'm working with. So can't really do that. But anyway, so yeah, there's only so much we can do in terms of moving clot around, and it's super important to be able to try and see underneath. So that really helps us move things along. It does not improve any clinical outcomes. It's really more for just our visualization.
I had a question about that. So twice I've ordered IV erythromycin, and then both times
fast enough,
it actually came up fast enough, and then I was told by the GI attending that I should have waited for the scope to for them to actually start like getting their stuff prepped before I ordered.
So it's tough with timing because while we can get everything ready, sometimes there's things that happen that delay us. So I think for this guy, actually, because this is a true case that I did when I was on service, we were about ready to start and the erythromycin had been given, but then they couldn't get a second IV in him because he's ESRD. So then the anesthesiologist said, okay, we're going to do a central line. I'm like, okay, well, that's going to add like another 20 minutes. So it is kind of hard. I've read other reports where the lowered limit can be 20 minutes. Sometimes it's just communicate with the GI team of like, we have the erythromycin, when do you want us to give it? When do you plan on scoping? So we can try and time that out. But I agree. Sometimes it's hard to do the timing because you can't predict if, the patient's going to decompensate further, need something, IV issues, things like
So
that.
best to order it, but then communicate.
Yeah, order
So
it and then
pharmacy
just
give it.
communicate, like, when do you want us to give it? When do you think you'll be able to scope?
I feel like if once you put the order in, communicate with the nurse too, just so they
Yeah.
don't, because sometimes when they come up, they just get right.
Yeah.
so
So
they
that'll
can
just to make sure everyone's on the same page. Yeah, because there is like obviously an ideal time that we would like to get that done in. Okay. Next slide. All right. I didn't go crazy into like varicose bleeding because I know that you guys have a hepatic emergencies lecture, and I didn't know if they were going to go into that. But obviously, patients with cirrhosis, ascites, varicose bleeding, they require a little bit different management. So if you feel ascites, you're tapping ascites on initial imaging. You want to do SVP prophylaxis, triaxone 1 gram for 7 days. And then your vasoactive agents. So you want to basically cause splenic vasoconstriction. So you want to vasoconstrict to the blood vessels leading to the abdominal organs to reduce portal hypertension, right? Because that will reduce the pressure basically in the varices and hopefully try and decrease the amount of bleeding. When I was a resident, I think fellowship too, octreotide was all we had. I know that terlipressin is now available in the United States. Have you guys, it's not explicitly approved for varicose bleeding. I feel like what I've seen on service is people are still using octreotide, but has anyone in your experience, curiosity, ever been using
It's
terlipressin?
restricted.
Yeah.
Restricted, so they won't even let you do it as an off-label thing.
Thanks,
Okay.
Rena.
Okay, so we have that for that. Okay, so person who mentioned Blatchford score, going to go into that. So this is our upper GI bleeding guidelines. So they mentioned the Blatchford score basically to see and risk stratify patients who could likely go home, maybe not need an intervention versus patients who should be admitted to the hospital, OBS unit or scope. These tests, and I'll talk about scores for lower GI bleeding as well, they are validated. And they say with a Blatchford score of 0 to 1, you are considered pretty low risk. So maybe can just follow up outpatient. However, where I trained at Temple, this never really worked for us because most of our patients, like for example, look at hemoglobin, had a hemoglobin, their baseline was less than 10 anyway. That already puts you at a score of 6. So I think it is a bit population dependent. I feel like the baseline hemoglobins I've seen here are a little bit higher in general, but still, like, as you can see, it's not really helpful. Being less than 10 is going to put you at 6. So it's something to, I would say, keep in mind, but I wouldn't obviously solely go by this because there's definitely people who I've had who say that they're bleeding or, concerned for melanoma with a hemoglobin less than 10, but they're technically at their baseline and there's no evidence of bleeding, right? So, not something to memorize, something to have handy, maybe to look up, but definitely not something to solely guide your clinical decision-making skills. Also incorporate, history, physical, vitals, and labs. So if you look at the right, this is a little algorithm that the upper GI guidelines talk about. So I think most patients that you're going to see are patients that are, you're not really making the decision of them going home as kind of the ED. So mostly you're going to be on the right-hand side, resuscitation first, erythromycin like we talked about. Once again, no recommendation for or against the PPIs, but I feel like we always do it anyway. And I don't think I'll change that in my practice. And then they usually say upper endoscopy within 24 hours. Obviously, if a patient's stable, it's over the weekend. We don't always fall in line with that, but that would be kind of the ideal scenario. Okay, we can go next. All right, so back to our patient. So he got 3 units of packed red blood cells and his hemoglobin went from 3.9 to 5.1. What are you expecting the patient to go up to? Yeah, like at least 7, right? Somewhere in that area, 1 unit for 1 gram, right? So we decided to scope him bedside because that was like a terrible response, and his blood pressure was still kind of waxing and waning at the time. All right, so this is what we found. Pixar didn't happen. Really believe in that. So he had a large ulcer in his gastric fundus. If you guys can see closely where that yellow arrow is, that is a visible vessel. So we have to treat visible vessels or obviously active bleeds, right? So you can go to the next one. So we treat visible vessels. You can clip, you can do bipolar cautery. So we decided to cauterize it. And if you could see in the middle, there's the yellow arrow with the bleeding vessel, and then the one to the right, you kind of don't see it as much anymore because we've cauterized it. So in the absence of any therapy, a visible vessel rebleeding risk from an ulcer is about 35%. So not insignificant. That's why they say treat it. Our guidelines actually don't mention, they can't make a recommendation for or against adherent blood clots. So if you irrigate an adherent blood clot, it's not coming off, you're not in the wrong to kind of leave it alone because it could be plugging something, right? Because if you do try and take it off and it starts spurting, you've got to be ready to deal with it. So, you know, I think that's more tending dependent of how aggressive some doctors leave it be and try and find that underlying region. But it is important, I think, at some point, could be outpatient, but to look again at that area because you don't know what's underneath that necessarily, to evaluate that area. Okay.
Back to
All right, so that was our first case, upper GI bleeding. Let's move on to case number 2. All right, so we have a 90-year-old female with past medical history of CAD. She's on Plavix, AFib on Xarelto, hyperlipidemia, hypertension, HFpEF, basically like a very sick lady. AD, diabetes, coming in with painless bright red blood productum. She says she had 4 episodes. She had a similar hospitalization just recently in March. So I think I saw this patient when I was last on service in July, earlier this month. So the bleeding at that time was felt to be hemorrhoidal, and she stopped having it. So she wasn't scoped. She did have a CTA showing a prominent vessel along the distal rectum. So everyone kind of thought it was a hemorrhoid. She was very stable. She doesn't remember the last time she's had a colonoscopy, and she's not having any abdominal pain, nausea, vomiting, or weight loss. So her BP is stable. Her heart rate is fine. Anyone want to comment on any of her labs?
Some like platelet consumption.
Yep.
Low hemoglobin.
Yep, so she's definitely dropped. Her baseline is kind of more in the 10s to 11. She's in the 8s, so that's something that is different this hospitalization than last, because before she didn't have a hemoglobin drop. INRs.
The BUN for creatinine is 24.
Yeah, okay, very good. So like some slight elevations there. But as you can see in the picture, that's pretty red, right? That's not melena. We're thinking more lower GI bleed. And her INR is a little elevated, you know, probably because of her DOAC use. Yeah. All right, so I just wanted to bring up the CAT scan from her prior hospitalization. So they noted the prominent vessel along the left posterior lateral area, thought to be a hemorrhoid, making note that she has extensive colonic diverticuli, but no areas at that time that showed like an active bleed or anything. And she did have some asymmetric mural thickening of her distal rectum, thought to be kind of averaging normal tissue without any convincing mass or anything like that. All right, we can go to the next slide. All right, so let's go back to Menti. Just next. Okay, so obviously, particularly in her, what do you think is going on? And then give me other differential diagnoses for lower GI bleeds. All right, so we've got diverticular bleeds. That's going to be your most common cause of lower GI bleeds, right? Someone wrote diverticulitis. You actually really don't see bleeding with diverticulitis. It's more the abdominal pain. There might be an abscess associated with it, plus or minus perforation. But you really wouldn't expect a bleed from that. Colon cancer, good. AVMs, anal fissures, hemorrhoids. Okay, yes, angiodysplasias as well. That can happen anywhere from the mouth to the rectum. Ischemic bowel, that's a really, really good one. That sometimes is kind of not the first thing people think of, but a really important thing. Okay. IBD, good. So we've got colitis, right? Infectious, inflammatory, ischemic. That's another important thing to think about. AMI. What's AMI?
Oh, acute respiratory.
Okay, yeah. Okay, another ischemic. Okay, got it. Okay, we can go back. That's a good list that you guys have. All right. Okay, so as we said, diverticular bleed, most common. You can see in the first picture that you have oozing from that tip. Super, super rare for us to actually encounter. I've never actually encountered a bleeding tick. I think most seasoned GI doctors will maybe see it like once or twice in their life. It's actually really rare for us. But if you see something with stigmata of bleeding or an active bleed, you can clip it, obviously, and that would help with that situation. Then we have ischemic colitis. You kind of get this very generalized pattern, almost like a blotchy kind of appearance. Important to biopsy these types of things because they can differentiate, obviously, ischemic versus more signs of inflammatory bowel disease. Colon cancer is a huge one, right? That's one that we really want to rule out, and especially in patients who have never had a colonoscopy, and we don't have any sort of luminal evaluation. And then kind of your general colitis, inflammatory, ulcerative colitis, Crohn's disease, infectious. And then I just listed some other causes, hemorrhoids, AVMs again. Post-polypectomy bleeds is a big one too. Patients typically would present in their first week, but they can present several weeks after, kind of depending on how big that polyp was, if they're on blood thinners, things like that. Don't forget NSAID-induced ulcers. You can also get colitis, like stercoral colitis, just from being so constipated and backed up. It's not as common, but it's definitely anything that's going to irritate or inflame the colon. Patients who have had radiation before. So always think that in your male older patients who have had prostate radiation, we see that a lot as well, radiation proctitis. Dual voice can happen here as well. Less likely, don't see this as frequently, but colorectal varices. And then something to always remember, if someone's having hematochezia and they are unstable, let us know because it could be a very brisk upper GI bleed, and we would at least want to do an upper EGD to rule that out. All right, so going to our lower GI bleeding guidelines, there's two different scores that they mentioned that are validated, but honestly, I don't think anyone really uses these clinically. So there's your Oakland score and your SHAPE score. So Oakland takes up that first and second half of the right column, and then the SHAPE score is kind of the bottom half. But once again, I feel like none of these are truly helpful, at least for the patient population that I trained with, because once again, you go to the hemoglobin, for an Oakland score of 8 or less, 95% probability of safe discharge. If you go to the hemoglobin, patients with a hemoglobin of 9 to 10.9 are already giving you a 13, and that's where most of our patients kind of landed anyway. And then for the SHAPE score, less than or equal to 1 indicated a hospital-based intervention, meaning any type of transfusion, intervention, endoscopic treatment is unlikely. But I feel like you kind of, how many patients are on anticoagulation and have a hemoglobin of less than 10.5 already kind of puts you in that category as well. So while these need to be more studied and more validated, but they do just mention them in the guidelines. All right. So for management, similar to upper GI bleeds, we're doing a more restrictive strategy, trying to get patients to 7, threshold of 8 in patients, maybe with cardiac symptoms. These guidelines go more into reversal agents and platelet management. We really don't give reversal agents too frequently unless it's truly someone with a severe life-threatening bleed. I forget, you guys may have seen this patient. It was because I saw a poster actually outside the gentleman who had Behçet's kept coming in with GI bleeding. I forget if he was on anything, but I dealt with him one time when I was on service, and he's someone who would just keep pouring out. Right, he's someone I would consider reversing just because it was so hard to like keep up with his life-threatening bleed. So we have a pretty high threshold for INR. If the INR is extremely elevated, you can consider reversing warfarin if they're on a vitamin K antagonist. But honestly, upwards of 2.5, we should be comfortable scoping without it. And then the same thing with DOAC, you can consider reversing these, really though, if they don't respond to resuscitation and cessation. So these aren't, things that we're doing regularly. It's kind of more case by case basis. And then if you are going to reverse warfarin, the guidelines recommend PCC over fresh frozen plasma because that's going to reduce the INR a bit faster. For platelets, ideally you want them above 30. For our procedures, 50 is kind of our goal. So if you have a patient who's experiencing that and we are going to scope, we'll try and get that to 50. All right, and then what are we doing for intervention? So I feel like colonoscopy is definitely the way to go to evaluate these patients. Our guidelines say non-emergent inpatient. There hasn't really been shown an improved outcome in patients had happened within 24 hours. Because remember, we got to prep all these patients too. And as I mentioned before, if patients aren't prepped, like we really can't see anything and there's not much we can do if there's a lot of solid stool around. And then obviously if a patient is hemodynamically unstable or very clinically significant hematochezia, get them to a CTA because that intervention with IR can be a lot faster than when we're doing a colonoscopy. Patients need to be bleeding at about 0.3 milliliters per minute for the CTA to pick up that bleeding. Okay, so that matters too. So in terms of management, this is kind of an algorithm that the lower GI bleed guidelines from ACG are talking about. It's basically the same thing as upper GI bleeds in terms of resuscitation first, transfusions as needed. If there's ongoing clinically significant bleeding, just try and get them to CTA. If it's milder, you have a bit of time, you can non-urgently give them a colonoscopy. And obviously, if the CTA is positive, contact IR so they can try to embolize the patient. Okay, so everything you've heard about this patient so far, all of her comorbid medical conditions, her age, the fact that she's bleeding, you saw what she put out. Are you gonna scope her? What are you gonna do? Toughy. Gotta commit. Okay, no scope. Yes. Scope. Oh. You're the attending. What are you guys gonna do? Okay to say you're not sure, but but I appreciate the commitment. All right. All right, so majority of you want to scope her. 5 people said no. For the 5 people who said no, what's making you hesitant to scope her? Yes, she's 90. That's scary for sure. Her comorbid medical conditions, her very, very complicated medical patient for sure. Okay, so. All right, so given her age and comorbid medical conditions, I asked cardiology to see her to deem how high risk is she. In patients who are older, definitely the more senior geriatric patients, I really do try my hardest to get family involved, children, just to be involved with all the decision making to really understand what's going on, because while these are low risk procedures for patients of these age comorbidities, they are not harmless. So she was deemed to be high risk, but she didn't have any modifiable risk factors. So given her hemodynamic stability, she was on Plavix, DOAC. We do need some time for that to wash out, right? Because if we're going to do an intervention on something I'm not able to use thermal therapy as much if she has all these blood thinners still in her system. So we just monitored her at that point, and then kind of was going to wait to see what happened in the washout period. I did ask colorectal to evaluate her because, in that prior hospitalization, people were concerned about hemorrhoids, just to see if they saw anything on endoscopy, anything that they could treat. They did not notice any external, or that's supposed to say internal hemorrhoids, no masses felt, but she did have some dark red blood. And they thought this was all related to diverticular bleed, given, she does have extensive diverticulosis. At this point, her bleeding had slowed down, but it was still present. So colorectal surgery recommended a CTA. And she actually did have bleeding from her, from a diverticulum. So I don't know if you can, it's like that little thing right there. So it's small, but it's what they pointed out. And I was actually very surprised that the CTA was positive because I didn't think she was bleeding that fast to have that happen. So she had colonic diverticulosis, no findings of valve obstruction. So this was done overnight. So they actually did talk to IR. She was clinically stable. She was mildly tachycardic, but normotensive. So IR basically said, give her resuscitation. We'll see how she does in the morning to see if we need to reevaluate, right? Because embolization is also not a benign thing. I've seen patients get ischemic from embolization because we're cutting off blood supply, right? So it's not necessarily a harmless thing. She wasn't bleeding the next day, so we kind of held off again. But she did complain of shortness of breath overnight, and the attending overnight gave her some Lasix because that's something they had been holding, right, in the setting of GI bleed. So we were going to plan for colonoscopy, but when cardiology saw her that day, she had a troponin greater than 3,000, new left bundle branch block, and they basically said she was having an active MI. So I definitely didn't scope her. So later that day, she had a bradycardic event, had a cardiac arrest, concern for complete heart block. Everyone thought this was cardiogenic. I went down to see her because I wanted to pray to God that she wasn't sitting in a vat of her blood, thinking that this was, related to GI shock, but she was not. This was all cardiac related. They paced her. She went to the cardiac ICU, pressure support, and they eventually transferred to comfort care. But the reason I bring this up is it was a diverticular bleed. Most diverticular bleeds do resolve on their own. However, it is a note in while our procedures are low risk, there is still a risk. So, you do want to proceed with caution for some of these patients, because looking back at this now, if I had done a colonoscopy a day earlier, I think I would have pushed this lady into cardiac arrest, while scoping her. So yeah, that's her story. All right, so that's the end of my talk. I hope from this you have a good idea of what to think about when you have an upper GI bleed, what to think about when you have a lower GI bleed. If it's a brisk lower GI bleed, it could be an upper GI bleed. So call us and we will see if we need to scope that patient more immediately. The differences between upper GI bleed and lower GI bleed, clinical presentation-wise, stable versus unstable. How are you going to evaluate these? For the uppers, a lot of it is, just taking a look. For the lowers, could be colonoscopy, but could be CTA if they're really unstable, and just comparing and contrasting those treatments. That's the end of my talk. Does anyone have any questions?
Yeah,
We actually had a patient in currently with a lower GI bleed from diverticulosis.
Mhm.
And we were talking with you, one of the recommendations was changing to a pre-existing Xarelto, changing to Eliquis.
Mhm.
And we were talking a little bit about this during the day, so I just want to get your take on why it takes advantage of the red rocks.
It has been shown to have decreased bleeding risk and bleeding incidences. So that's basically why in studies they've shown that. Anecdotally, I don't know if I've noticed a difference because obviously we can't follow the patients throughout and see if that's actually decreased their risks, but that's a big reason why. And for some patients, so a lot of times we'll get calls from the inpatient team saying, can we restart the blood thinner, right? And it's a hard question to answer sometimes, depending on what we found, because if they have a high risk of rebleeding, if I have a patient, it's ischemic colitis, things like that, they're probably high risk of rebleeding again. But it's a benefit risk discussion about how badly do they need it, and if they need it, we can always try and treat the bleeding again. But sometimes I will recommend switching the DOAC if cardiology is okay with it, to try and somewhat decrease that risk of bleeding.
Another question. So patient with low GIP, when do you kind of involve colorectal cancer, colorectal surgery with, GI and then, IR, because they said unstable bleeding.
Yeah.
In my head, I'm like, I don't know if GI could do much at that point. Would that be more of a surgical aspect or would IR be helpful?
So in my opinion, surgery will always ask us to scope first
Okay.
because surgery is it's a big thing, right? It's way more invasive than a scope. Where I trained, there was a guy who had diverticular bleeding. I think he went through 3 colonoscopies because he would bleed, stop, bleed, stop. He went through multiple CTAs where he couldn't quite catch it. And after that point, when he kept bleeding and we were like, we're not going to find it, that's finally when surgery took him to do like a partial colectomy. So I do feel like we're always going to be pretty much the first line. If someone is truly hemodynamically unstable, I would get them to CT because that might be faster than us getting ready and doing the scope and all that stuff. It's usually going to be one of those others. And it's always fine to, I always think it's better to get consultants in early. And if they say they're not going to do an intervention, that's fine, but then they know the patient at least ahead of time. But I do find it very rare that surgery is the first option kind of thing. It's usually like we have to do our evaluation. And then if we find something, can we treat it? If we can't treat it, and then we go to our surgical colleagues.
Okay.
The reality of it, and when you're in this situation, because this is unfortunately something that we see just a lot, you're not alone. There's usually your senior with you, another resident, and usually, like from my experience in any of the second or third years, you can chime in as well. This is all kind of happening at the same time. Someone's placing in the CTA order, especially if it's an unstable patient, talking to IR probably first if they're truly that unstable, and then someone else is talking with GI and surgery all at the same time. And it's moving in very fast motion, but that's like how these decisions need to be made. It's particularly in divergent. They're so frustrating to take care of.
Sometimes they stop, sometimes they don't, sometimes they, but like for the Behçet's patient, I did recommend like a CTA, but he just kept pouring out. It's too unstable. So then we just decided like he's not even stable enough to get CTA. So let's just scope, take a look down. And I think we found like a jejunal something and tried to clip it. So yeah, it's a moving target basically, kind of depending on how the patient's doing. But, always reach out to your upper years. You can always reach out to the GI fellow on call too for prelim recs as well.
I think that's also why we place a lot of emphasis on calling consults in a specific way, because there's just a one-liner looks very differently or sounds very differently to the GI team for like a GI bleeder overnight or maybe on like a long call admission versus a regular consult that happens during the day for like an AKI, something. You have to give the right information, be concise enough, but also have the same amount of like priority or urgency in your voice when those situations are involving more unstable patients.
Like if you're calling the fellow overnight, it's because you're asking like, does this patient need to be scoped overnight? That's the biggest thing, right? So having that sense of urgency will definitely be relayed.
I have a question about the upper GI taste.
Mhm.
So, in a case like that where you have like a fundus ulcer and like and a vessel that you've like managed, how does the PPI management look after? Because I've seen so many different ways people do it. I've seen people do like continuous PPI IV for like 2 days. I've seen 3 days, and then so
it's usually recommended to do the PPI drip for like at least 3 days. Then you can kind of go to high dose BID. The guidelines say you want to continue that for 2 months, but I feel like in our practice, we typically just say, just continue that until they see us outpatient, because they're going to need a repeat scope in 2 months anyway, just to make sure that the ulcer is healing, making sure it doesn't have any like malignant potential to it, things like that. When you see something that has a high risk of bleeding, high stigmata, or something that was bleeding and we intervened, you want to do IV PPI for like 3 days, and then you can switch them to BID.
And that's like continuous drip, or is it like BID?
So the guidelines say continuous drip. So I would do that. I think you could go to PPI BID because if they're going to be off the floors, because once again, they kind of show that they're not inferior to one another. I still think that's fine. Anything else? Well, thank you guys. Hope you guys had fun. Oh, sorry. Such a pet peeve. I'm not prepared. I bring like
No, it's
one.
my fault. That's not
You made it.
Yeah.